Thanks for joining us. I'm Dennis Holmes. I'm a breast cancer surgeon and cancer researcher, and I'm joined by Sharon Merritt, a patient advocate who's now internationally renowned as such. I think many of you know or have heard in the past why I do what I do, which has been all about sort of trying to improve the treatment options for breast cancer and reduce the burden of care. But Sharon, why don't you tell me why you do what you do?
Well, because first of all, I'm a breast cancer survivor, and I did most of mine holistically. And last year I found out about you, and I had my tumors frozen, and I was very impressed. And I just I picked up your passion, and then now I really try and keep the ladies from having to go through things they don't have to. It's just I was so blessed with my journey that I'm trying to pay it forward. So it's become a ministry. I don't get paid for any of it. I don't get any compensation whatsoever, except the pleasure of helping other people.
And you've done that tremendously. So thank you for that. I agree with your expression of it as a ministry, because a lot of the work that I do and as the researchers do is not seen. It's sort of the hours of toil over the weekend and at night into the wee hours of the morning, trying to understand problems and develop solutions. But it's because they believe in the mission and want to make sure that we continually raise the bar and make things better. There's this notion of the standard of care. The standard of care is sort of the minimum that you would expect the patient to receive as part of a treatment. But the standard of care, I think, should be the floor. It's not the ceiling. And we should always try to improve upon what we're currently doing to make treatment options better, to have options that are adapted for the problem. And so that's the context in which I approach this. And this effort to sort of expand how we think about and understand about breast cancer. We have created the opportunity for patients to submit questions and have those questions answered. At least we do our best to answer them. You have collected a number of questions. I thank you for doing so. So whenever you're ready to get started, we can take one question after the other and
go for it. Okay, what are the scenarios where someone would be a good candidate for cryoablation? Do you require all individuals seeking cryoablation to present with certain characteristics of breast cancer? What are the parameters specifically you would exclude someone from being able to undergo the procedure?
Okay, so thanks for starting off that one question with three. Let me make sure the volume is turned up. Cryoablation is one of the tools that's available to treat breast cancer. It's not a well-established tool. It's an emerging tool. And with most emerging tools, we usually start with the simpler problems, the problems for which the tool is best designed to treat. Cryoablation is a technique that's been used for decades for treating various other types of cancers. We now have a strategy for treating breast cancers. There's a device that was developed called a cryoprobe. It's a needle-like device that is capable of freezing consistently an area that's about 3 by 3 by 4 centimeters, the area of an oval that's about 3 by 3 by 4 centimeters. So any type of cancer that you consider for cryoablation, in most scenarios, would need to fit well within that area. So that's the first kind of criteria. The criteria is the size criteria. It needs to be something that could fit easily within a 3 by 3 by 4 centimeters oval of tissue, including having room for a margin around it. So most patients that were considered for cryoablation in the early studies, and even now in most cases, are people that have a tumor that's 2 centimeters or smaller, because that would fit nicely within a 3 centimeter area. Now, there are exceptions to that, and there are some ways of expanding the indications, but that's really the best scenario, and where there's very little question that it would work very well. Now, as you get to larger tumors, you kind of lose the opportunity to treat effectively with a single cryoablation. We have expanded the limit to some degree by using a series of overlapping ovals to treat tumors that are maybe 3 centimeters or sometimes bigger. That's mostly based upon data that was developed in the treatment of liver tumors or kidney tumors, we're basically applying it to the breast because at least the principle has been proven in other sites that you can do this approach and treat a larger tumor. But that's really becomes an option for someone who simply does not want to have surgery. The preferred option would still be a surgical approach for someone with a larger tumor because we don't really have a significant body of data showing that it's safe to do in that situation. We've done a number of smaller trials, and some trials with reasonably long follow-up looking at the tumors 2 centimeters or smaller. We just don't have those trials for tumors that are larger for breast cancer. So many decisions come down to making decisions on a case-by-case basis, balancing what we are capable with doing with what the patient is willing to have performed, and trying to find the balance in fulfilling her treatment desires, while also dealing with the reality of the technology and the limitations of technology. So that's why I sometimes end up treating larger tumors that are not ideal. But the ideal tumor would be the one that's 2 centimeters or smaller, and that is well characterized by imaging. Where the imaging, whether it's mammography or ultrasound, MRI, all three show a tumor that has pretty clear edges, pretty clear borders, where we can target like a bullseye and be confident that we've positioned the oval around the tumor well enough that we can treat it confidently with a clipboard. I hope I answered all those 3 questions in that one response. But
recent studies support that cryoablation appears to have a higher chance of success than surgical therapy for localized tumors and other ablated therapies.
I think that's a debatable point. Now, obviously, I'm an advocate for cryoablation, but I also try to, not be such an advocate or an enthusiast that I leave people with the impression that it's capable of doing more than it can do. It really comes down to the problem you're addressing. So it's about comparing apples to apples and not apples to oranges. So if you're looking at a tumor that is well characterized, as I described, and that's under 2 centimeters, and that's treated with cryoablation, and it doesn't have some certain other risk factors like a positive node or extensive intraductal component. So if you take the people that are the best candidates for cryoablation, and you compare it to patients that have surgery for the same problem, I think they're equal treatments. And I think that the evidence would suggest, based upon not randomized but prospective studies for people with small tumors treated with cryoablation and radiation and medication, because that's comparing apples to apples. When you compare those patients treated with lumpectomy and radiation and medication, they do just about as well. A recurrence rate over 5 to 7 years of about 1 to 2%. That's what you should expect with lumpectomy and radiation and medication. And if you choose the right tumor, it's what you should expect for cryoablation. That's the comparison. The comparison is not a bigger tumor treated with surgery versus a bigger tumor treated with cryoablation. We just don't have evidence long-term showing that the bigger tumors treated with cryoablation works as well, partly because with surgery you can get margins. You can figure out if the margins are clear, and if they aren't, you can offer the patient mastectomy. With cryoablation, we don't really get margins, so we can't give that immediate feedback that yes, your margins are clear, therefore you don't need to have a mastectomy after cryoablation. So we have to wait to see exactly what happens. And so it's not exactly a head-to-head comparison, and we also haven't done it yet, so we don't really know the data. But I would just like to add to the discussion that there's been, to date, no direct study comparing lumpectomy to cryoablation for these tumors. We're looking at studies that looked at lumpectomy, studies that looked at cryoablation, but not a study that looked at both in the same study. But I have been working with the company Hologic now to develop a clinical trial. I might have mentioned it previously, but it's intended to be a randomized controlled trial. So it'll start with a group of women, about 2,000. They will be randomly assigned to receive lumpectomy or lumpectomy or cryoablation. And then they'll receive the selected treatment, and then it will be followed over a period of 5 to 7 years to look at the outcome. That is a study that needs to be done. It hasn't been done, but it's the type of study that is required for cryoablation to get the sort of respect that it needs, but also to become widely accepted as a treatment option, because all of the other breast cancer treatments that we offer for women are based upon randomized controlled trials. It's the standard approach that we use. It's the gold standard, in a sense, that we use to judge the validity of a treatment. That eliminates bias of the patient, bias of the physician. We randomly assign the treatments and then look at the outcome over time. That's what we need to do. That study is in the works, and I met with the company last weekend, and they think that maybe it'll be ready to launch by the end of next year.
How long does it take for the cryoballs to dissolve?
I guess this is the cryoablation segment of the Q&A?
Yes.
Okay. I do the other things, and the other things are important.
Oh, we'll get to those.
But so this is also an interesting question, because it's a question for which we have the answer isn't clear and it's evolving. So what we do know is that based upon patients that we were treated with for fibroadenomas, benign tumors, and for patients that were treated for a single cryoablation of a tumor, say 2 centimeters or smaller, so patients that receive one ablation of a small lesion, that it typically takes about 2 to 3 years for the lump that forms from ablation to disappear and not be detectable by exam. Now, that question or that answer assumes many things. Number one, it assumes that the rate of absorption will be in a typical fashion. Not all breasts are have the same texture
Or density.
and density. Yes, I think that dense breasts heal faster than fatty breasts. So an older patient with a fatty breast is less likely to have it heal this fast, and so her time period for healing might be longer than a younger breast. There's the issue of closeness to the skin. Obviously, if the tumor is close to the skin, then you'll be able to feel it for a longer period of time before it disappears, as opposed to one that's near the back of the breast that might be hard to feel quite early on because it's just farther from the fingertips. I talked about density, you mentioned density. There's also issues of age. Sometimes when breast tissue heals, it forms fat necrosis. Fat necrosis happens from any intervention, whether surgery or a biopsy or cryoablation. Areas of fat may die as a consequence of the procedure, and fat, when it dies, often gets hard. It doesn't necessarily get soft. It may get hard. Sometimes it may get rock hard, especially if it forms calcium deposits. So in an older breast, there tends to be more fat, and there's a higher potential for fat necrosis. And fat necrosis may take a much longer time to go away. So there are some unknowns about this, and I think as we're expanding our experience, we're getting a better sense of how long it's taking. So each year, I started by saying 1 to 2 years, and now I'm saying 2 to 3 years, and increasingly I'm saying 3 to 4 years, as the mixture of patients, kind of becomes more diverse. The last factor is size of the ablation. I mean, if it's a single ablation, all the things that I've said so far pretty much apply. But when you start adding a second or third ablation to it, a much greater volume of tissue, then you have a much bigger effect, a bigger potential for fat necrosis. Obviously, it's closer to the skin now, and so it would take a longer period to go.
How long does it take for the aches and pains to go away after the cryoablation? Or how long do you have aches and pains after the cryoablation?
So I think to some degree it relates to the question I just answered.
Well, this one comes up a lot with the ladies with me. And I know with me, I still have them, and it's been a year.
Okay. So this is what I tell, I'll make it clear in the consent form if it needs to be clear, but I also tell surgical patients that there's an initial acute injury. So the pain that happens related to the treatment in the first 2 to 3 months, it should diminish dramatically. But with any breast treatment, and this includes breast biopsy or breast surgery or cryoablation, there's a tendency for there to be stabbing wounds of the pain that kind of come out of the blue, unrelated to what you do, which may last for years. It diminishes over the years, but it's a pretty consistent symptom of breast an area of breast treatment, and it happens after mastectomy as well.
Does temperature affect it?
I don't think no one's related that to me yet. Maybe it does, but no
'Cause
one's
it seems like
communicated that.
I've noticed it more like in the pool if it's cold, or sometimes when the weather is cold.
Well, I mean, the nerve, it is a nerve
Right.
injury or a response to a healing nerve. And so if there's another stimulus that can affect it, it is plausible that it could react to temperature changes. But it's an expected, it should be an expected
And
response.
I think the problem is that, once you've been a cancer patient, every time something different happens or you get a pain or an ache,
Yes.
you go right to that. And then I know for myself, I'm constantly having to tell myself, oh, wait a minute, I had stomach pains before. So what's the difference now?
Yes.
Or I had this before or that before.
Yes.
Because you are so in tune with the thought that something else might happen. I think that's where that question comes from.
I think it's, it is a reality of having a cancer diagnosis that all the little aches and pains that you dismissed previously now become a reason to worry that you've had a recurrence. And you just have to kind of just keep giving yourself a reality check.
But that's what I do. I just think, wait a minute, I've always had this, so why would it be any different now?
But this is a specific treatment-related effect. And so whether it's from any of the invasive procedures, when there's a nerve injury, which happens, the nerves, the reason why the breast has sensations, it has lots of nerves, that is an effect that it should be expected. But the pattern is, it comes out of the blue. It might be a shocking or electrical or stabbing pain, and then it goes. And sometimes it happens in a pattern where it happens more frequently. But over time, it should become less and less frequent. But it may last for years.
That's what I think.
The other pain, I'm sorry, that I want to mention, is usually there's tenderness to pressure. So if you press on the spot, then there's pain. At least what most people communicate to me, that it doesn't hurt except for those stabbing pains. It doesn't hurt unless you press it.
Right.
And that's a typical pattern. And that should diminish as it heals.
Okay, this is a little bit the same. Does it only work for small tumors that have not spread to other parts of the body?
Well, yes and no. So it's best for small tumors for the reason that I described. Now, if you have the ability, the technology to expand the area that you cryoablate, then you can potentially treat larger tumors. But eventually, it becomes impractical to treat a very large one if you're going to need 15 ablations,
Well, I think part of this question might also be, though, not spread to other parts of the body.
Right, I'm going to get to the second part of the question. So the first part is, dealing with the breast. So as a breast treatment, if you can ablate a sufficient tissue with an adequate margin, then it works, I think, as well as surgery in most cases. But cryoablation is a local therapy, meaning that it only treats what you target. We can talk about whether that has a benefit outside the breast, but the primary purpose is to treat what you see. If there's already disease in other parts of the body, then those areas need a different solution, whether it's lymph node surgery because there's lymph node involvement, or whether it's drug therapy because there's systemic disease. Those are still true. That is also true if you've had a lumpectomy. If you have disease outside the breast, you still need to have a solution for the disease outside the breast. If you had a mastectomy, you still need to have medical therapy because if it's invasive breast cancer, there's potential for the tumor to be in another part of the body. So cryoablation really is, if you want to have the best results with cryoablation, as with lumpectomy, you have to approach it as one of a multiple pronged solution. It's a local therapy primarily, but breast cancer is generally a systemic problem, meaning that at some point you have to worry about tumor cells that have escaped the breast to go to other parts of the body. And so, you have to also have a plan for those things. And that's why we talk about lifestyle changes and medications and radiation and so forth.
I just wonder if their question is more on the sense of, if it has gone somewhere else, can you still do the cryoablation? Because obviously it's not going to fix anything anywhere else.
Just like you could still do surgery on the breast or mastectomy on the breast. You have to, it treats a part of the problem. It doesn't mean that you can't have, cryoablation if you have metastasis to the lymph node or metastasis to another part of the body, stage 4 disease. but you also need to have an effective remedy for those
Oh, yeah,
areas as
sure.
well.
After cryoablation, when you say the body does away with the tumor over time, do you know, we already, roughly how long this healing process takes? Is it months or years? We already did that. Can the dead tumor come back to life if the body cannot get rid of it completely?
Well, having done cryoablation procedures and seeing patients that have been treated by other people and have also, performed or recommended biopsies of cryoablated tumor now for 10 years, the pattern of recurrence that's pretty clear is that recurrences happen at the borders of the cryoablation area. So assuming the cryoablation device worked and you targeted it accurately and you targeted the tumor that was truly there, because you had imaging to guide it, I think there's every reason to expect that the thing you target that will be at the center of the cryoablation zone will be killed. But that's not really the place where it's likely to recur. So that doesn't come back. That's the answer to the question. Where it's likely to come back, if it comes back, is at the edges in an area that looked clear at the time that you gave the treatment, but in reality had disease present that was microscopic and too small to see. That's one reason why we try to add a big margin, so you have a little bit more of a safety zone around the tumor. But even with lumpectomy surgery, we go to surgery, we remove an area thinking that we have widely clear margins, and you find out that, well, there was actually tumor in a place you didn't see. This happens all the time. So it's a limitation of imaging that we have to deal with. But based upon the experience, I'm increasingly convinced that the cryoablation works for what you target. It's not an issue of whether or not the chill is cold enough to kill the cancer. It's whether or not you ablated enough area to treat the true extent of the disease.
Why is it mostly done by radiologists and not by more surgeons?
I think there's several answers to that question. The most obvious answer to the question is that radiologists have the technical skills. The radiologists, by training, are used to doing needle-guided procedures under ultrasound guidance. And so it's just a natural thing for them to sort of add to their skill set. Now, I don't think that's the right answer, but that's technically how it's done more readily. I think, as I've already articulated, I think the problem with radiologists doing it is that, treating breast cancer is more than just inserting a needle into a problem. It's having these kinds of conversations about the multimodality treatments, how you make cryoablation work in the setting of a positive node versus, stage 4 disease, dealing with the biology of the tumor and drug therapy. It's a much more complicated discussion. And there's also, it also isn't the nature of radiology for them to do follow-up exams and follow patients over time. They follow them by imaging, but not as part of a comprehensive follow-up plan. And so I think if a radiologist is working with a surgeon or someone who's taking responsibility for managing the patient and not just a tumor, then that's a situation where radiology probably works okay. But if it's just someone who doesn't help own the solution, the global solution, like caring for the patient, then I think that's a situation where the radiologist as a technician might be inferior to a surgeon. Surgeons are used to coordinating care with other specialists to make sure that the patient's tumor is treated comprehensively. And if they're treated comprehensively, it's not necessarily where radiologists are. Now, why do not surgeons do it more often? I think it's partly technical skill, but there's also the reality that surgeons tend to be more conservative in their approach to problems because, they are driven by the standard of care. Few people want to be an outlier, want to treat outside the standard of care as they see it, because that's a risky place to be. Medical legally, it's a risky place to be. It's also a place that's often discovered by your colleagues, by your medical oncologist, your radiation oncologist, because it takes them out of their comfort zone. And so it really needs to have someone who's willing to push the limit. And I think there's many ways that surgeons push the limit, but I think that's a small number of surgeons. It's not the average surgeon. And then there's also kind of the billing question as well. Generally speaking, for anyone, in medicine, in order to do a procedure and get reimbursed for it, there has to be a code, and the code has to have a value assigned. Now there's a code, but there's no code with a value, and so that's a moving target. So I think in a few years, there'll be established codes, there'll be established value, and there'll be established data from the randomized trial to say that this is equally good as the alternative. And those three parts are really what's needed to open the door for treatment to become widely available, and whether it's performed by a surgeon or radiologist.
What's the long-term outcome what long-term outcomes have you seen?
I've seen the range of outcomes, and it's really comes down to the range of problems. So, I'm always very cautious about answering this question, because I don't want to give people sort of false hope, but also don't want to discourage them.
Well, I guess it's kind of back to the lumpectomy cryoablation issue, that the outcome's probably pretty close.
Right, for the problem you deal with. So for the patients that are ideal problems with cryoablation, I think their outcomes long-term are very good. Low risks of recurrence, low rates of recurrence over a 5 to 10 year period. That's what the evidence shows now. Those patients are treated with cryoablation, medication, and radiation. Now, if we take one of those components away, the recurrence risk goes up a bit. Maybe instead of 1 or 2% in 5 years, to 3 to 4 or 5% in 5 years. So that's patients have the freedom to make those decisions. Decisions do come with some cost, but for these small tumors, the cost seems to be a low cost. I think as you get to bigger tumors or higher risk tumors, the risk goes up. The risk goes up with surgery, but it also goes up with cryoablation, because cryoablation is only a part of the solution. The solution really becomes, radiation becomes more important, medication becomes more important. And I've treated the full spectrum of patients. So it would misrepresent cryoablation to say publish my numbers when my numbers involve patients that were treated exactly according to protocol, and those who did cryoablation and nothing more, even though something more was strongly recommended, because their risk of recurrence was so high that it was just more a matter of when as opposed to if. Right. And so I think and I have a lot of those patients. That's why they would skew the data. And so,
I can think of one in particular.
I can think, yes. So it's an answer that people want to know. And I guess when we have sufficient numbers of them and sufficient follow-up, we'll be able to say. But I think we haven't done it enough now. I mean, the peak time of recurrence, especially for high-risk tumors, is at about 2 to 3 years. So until you get out to 5 years, you don't really know the pattern of recurrence. And my limits, like what I've been willing to treat, thanks to you and others, has expanded greatly in the last 2 years, because basically patients have sort of pushed me to try, and I've been willing to try, but we don't really have enough follow-up of those patients to say. So maybe in 3 to 4 years, I'll be able to say, okay, based upon that experience from 2020 to 2021, this is what we should expect. But it's too early to tell.
I do want to bring up one thing, though. How long have you been doing this? Because people keep come up and say, oh, it's experimental, it's this and that and the other, but you've been doing it for a long time.
Well, I started performing cryoablation of benign tumors in 2003. So at least I've been doing cryoablation for many years, and started to treat cryoablation of these ideal breast cancers in 2009. So my global experience is 18 years. My experience in cancers has been a 10, 11-year experience. And my experience with these larger cancers is more like 2 years, 3 years.
I guess the point I wanted to bring out is just that it's not something new. It's not something that, people think it's new, but it's not as new as they think it is.
Right. I think with many things, there's a learning curve. And so I have had a very long learning curve. And I've also have a learning curve that's evolving as I learn how to adapt it for different approaches. But there are two things that I can state emphatically that are clear. Number one, it kills what you target. So I have sufficient confidence, having re-biopsy patients repeatedly, not repeatedly, but over the years, we've continued to recommend biopsies. And we have ongoing confirmation that the thing you target is killed. But the other thing that I state with equal strength is that our ability to target is limited by the quality of imaging, by what is seen. We tend to recommend a lot of imaging, mammography, ultrasound, MRI, because we want to see it at every angle that it can present itself. But even when you have all the imaging available, there's still some features of cancer that just might not be detectable yet. And so, there's always a little bit of uncertainty, which is only assessed by time, most accurately assessed by time, to see if something emerges. And because of that uncertainty, that's why there still is, as with lumpectomy, a row for medication, a row for radiation to get what you don't see. And you can, on an individual patient basis, say, well, I'm not going to use radiation, I'm not going to use medication. That's fine. People have the freedom to do that. But they have to also understand that there's a potential risk with that, right? Because I can't tell you that just because your mammogram and ultrasound MRI say it's exactly 2 centimeters, that it's really only 2 centimeters. Because cancer cells may take years to become detectable, and that might be surrounding areas that are developing that have yet to become detectable. But in 2 or 3 years, they might become detectable. And that's when we'll see them, and then we'll be dealing with the recurrence. And that's true with lumpectomy as well. Cryoablation doesn't protect you from that.
After you do cryo, how do you know the margins are clear, or is that something that imaging can do?
I think
I think so.
We use the best imaging that we can. We make an estimate of the size, and then we overtreat that volume. We add an additional 1 or 2 centimeters if we can around it. The smaller the tumor, the bigger the margins you have, or the more ablations you do, the bigger the margins you can get. But that's how we balance an uncertainty, manage uncertainty.
How effectively do you believe cryoablation will be permanently removing a DCIS area with DS? And can you give a percentage?
Well, I think it's. I'm pretty confident, but it's a question that still is under investigation. Meaning that most patients with invasive cancer have coexisting DCIS. The DCIS gives rise to invasive cancer, and usually most people have both parts in their tumor. And when we do the biopsies, 6 months after cryoablation, which what we generally recommend, we see no evidence of either. No evidence of DCIS, no evidence of invasive cancer. So if they were both there, they're now both gone. So that proves the principle that it can kill DCIS. So the problem with DCIS is not whether or not the cryoablation can kill it. I think that point is proven. Question is, can you see it well enough to target it? Because DCIS, if it's sitting inside of a mass, then it's an easy target. But if it's little tendrils extending out from the mass, we might not be able to see it. And so the question is, does your imaging show it well enough to target it? As you know, we're doing a DCIS trial,
right.
And that trial is open to anyone with a tumor, DCIS tumor, 2 centimeters or smaller. There's no cost to compete for. We do the cryoablation for free, and the idea, actually, to be correct, we do bill the insurance,
right.
But if insurance doesn't pay, we don't charge the patient for it. That's a more precise answer to the question. But the idea is that we're using it as a proof of principle to show that cryoablation works for DCIS, so we can expand it. Because the criticism was, those other trials are trials of invasive cancer. Is that really applicable to a trial of pure DCIS? So answer the question is to do the trial. And so we're taking patients with DCIS detected by virtue of a mass or calcifications or enhancement. They all undergo another procedure, which is to have an ultrasound visible marker placed at the site of the DCIS, because DCIS is not usually ultrasound visible. Some are, but probably no more than 5%, 10% at the highest. So there's no clear target for cryoablating them, for pointing the cryoprobe. In order for them to become a candidate for cryoablation, we need to create a target that we can aim for. And the way that we do that is to have the patient undergo a procedure prior to cryoablation where the radiologist places, under mammographic guidance, an ultrasound visible marker next to at the site of DCIS, either at the site of the residual calcifications, or if they have a clip currently, next to the site of their existing clip. And then we can aim for that. And so that's what the trial is. Those are the aspects of the trial that the patient selected based upon the size of DCIS, the appearance based upon imaging. And then we have a marker placed, so we have a clear target. And then we aim for that target and treat with a larger volume of ablation, 3 by 3 by 4, to treat their maximum 2 centimeter DCIS.
How do you know if it's multifocal DCIS and is cryoablation appropriate for those with multifocal DCIS?
So multifocal DCIS means multiple areas of DCIS within the same quadrant of the breast. And generally speaking, DCIS has a higher tendency to be multifocal than invasive cancer, just kind of a feature of how it grows. It's also one reason why there's a little bit of more concern about it recurring, because there might be other spots. But as with most things, it comes down to patient selection. If you can perform a lumpectomy on a patient with multifocal DCIS, in theory, you should be able to perform cryoablation. It really comes down to mapping the extent and designing the lumpectomy or the cryoablation in a way that covers the extent. Last night, I treated someone who had multifocal DCIS. It was basically kind of L-shaped, and what we did is we use 4 ablations to cover that L-shaped. If I had taken her to surgery, I would have cut out an L-shaped area as part of the lumpectomy to get the area. So that's kind of how we do. So it's all about how reliable the imaging is to show you the extent, and then planning a surgical or an ablation approach to cover that area. What we aim to do, as with surgery, is if you have something here and something here, we assume they're connected. So it's not like we treat this area and then leave this area and treat it and then treat that area. At least if you were to look at it under the microscope, the whole thing, likely there's a connection between the two that you don't yet see.
I think you did that with mine. I had 2.
Yes, I assume that they were connected, because likely these are 2 independent things that are happening in completely unrelated parts
Well,
of the
the
breast.
biopsy came back, they were exactly the same. So
Case in point. So that's how we we don't just aim for the foci. We have to deal with the tissue bridging between the two, and we do that whether we're doing surgery or cryoablation.
does cryoablation work for lobular as well?
So all the things that I've said so far about cryoablation and its limitations are even more so with lobulars. The reason for that is that lobular cancers, because of the way that they grow, certain properties they have, the cells tend not to stick together. For the typical ductal cancer, it's almost like sticky rice, if you will. That the pieces, the cells tend to want to stick together because the cells produce a protein that facilitates its binding to the next cell. That's how ducts are formed, because one holds hands with the other, and then they form a tube, and that's a duct. That's why they have a tendency to stick together. They're inclined to form ducts, so they have to hold hands to do that. But lobular cells don't form ducts. They don't have that tendency to stick together. And because of that, it's more like dry rice, where if you put it on the table, some pieces will spread out, And so because of the spread, we can't always be certain that there's not a straggler, 2 or 3 or 4 that's 5 inches away from not necessarily that far. But
so it's more likely to have a reoccurrence, probably.
Well, there is a greater potential to have a recurrence if you have removed it and you haven't proven that you've gotten around the whole area. And so that's why, it is more of a challenge. It's a challenge for surgery. We often take these patients to surgery for their 1 centimeter lobular cancer that ends up being 5 centimeters. And we have positive margins because although it looked this big, when they looked at it in the microscope, they saw these other cells that were several centimeters away. Now, it doesn't mean that all lobules are like that. most lobules are in fact focal, but there are enough of the big ones that it really challenges the way we treat them. So the decision to treat with a lobular is based to treat a lobular with lumpectomy or with cryoablation is a case-by-case decision. Mammography often doesn't show the extent. MRI is the best thing for showing the extent, but it's not perfect. It's just better than all the others. But we basically use imaging to get the best estimate, and then we overtreat because, again, we assume that it may be larger. If I were to treat that patient with lumpectomy, I would take wider margins than I would typically take for ductal because of the same problem. I would rather a patient with lobular have surgery because of these uncertainties. But if surgery is not something they're willing to consider, then I think cryoablation is certainly better than watchful waiting or just treating with medications or doing things that aren't definitive. We can ablate what we kill. We can kill what we ablate. We can kill what we ablate. But we have to worry that there are things that we didn't target. And that's why the follow-up will be more important for those patients.
Would someone with DCIS 3.5 centimeter grade 1 ER positive, HER2 negative, along with a microinvasion of a spot of lobular carcinoma, 0.7 millimeters, be a good candidate for cryoablation? Also, what kind of biopsy do they need to monitor, needle or stereotactic?
Let me take a look at this one. Okay, so let's look at the size. So the size is a little bit too large for one ablation, whether it's ductal or lobular. So if, and whether it's invasive or not, this is actually in case of both invasive and DCIS. So let me answer the question in parts. So whether it's DCIS or whether it's invasive cancer, if we would treat something 3.5 centimeters, it would require multiple ablations to cover that area. And we would sort of figure out how much extra margin you need based upon the characteristics. DCIS would benefit from a wider margin. A lobular cancer would benefit from a wider margin for the reasons that I mentioned, because they're harder to see the edges. The receptor status doesn't really matter so much from an ablation perspective. I think that ablation works just as well for estrogen receptor positive cancers as negative for HER2 positive or negative. It's a matter of the anatomy. If we can see it well and target it well with an adequate margin, it will work as well. The receptor matters because it affects medication decisions. It affects the risk of recurrence in the lymph nodes. It affects the risk of recurrence outside the breast as well. But it doesn't necessarily influence your lumpectomy options or your cryoablation options. They're candidate for lumpectomy. They're candidate for cryoablation, in theory at least, based upon size. And then, I recommend for patients that have cryoablation, I recommend typically the biopsy at 6 months post-cryoablation to allow some of the healing changes to take place, some of the imaging changes to settle down. So we give a bit of time to that acute injury heal somewhat, so that the findings that we see on the imaging are more reliable, and we could more easily compare, one patient to the next. If they're all getting imaged at 6 months, then we at least get an idea of what to expect at 6 months. Some are getting at 1, some are getting at 2, some are getting at 3. It becomes a little harder to compare those. But the biopsy, we typically recommend an ultrasound-guided biopsy to target the center of the cryoablation site. Alternatively, if calcifications was a major feature of their diagnosis, then a stereotactic biopsy could also be performed. But typically,
what's the difference?
Ultrasound is done on the ultrasound guidance with the ultrasound and the needle.
Right.
Stereotactic is a mammogram-guided biopsy,
Okay.
so the breast is in compression by mammography because the thing that they're aiming can't really be seen well by ultrasound, and they're using the mammogram to position the needle.
Okay.
Usually, if a patient has tumor that has calcifications, when they do the biopsy and the ultrasound, they'll get some of the calcifications as well, because we'll x-ray the specimen, we'll see that the calcifications inside. So it gets both the center as well as the calcifications, and then we can very confidently see that there's no tumor present, and although we have calcifications, there are no cancer cells surrounding them anymore. And that would prove that we got the right spot and we don't see cancer there. So it really was very reassuring finding. But usually it's ultrasound guided biopsy as the preferred.
Okay. Post-procedure expectations, what to expect from minimal treatments to more extensive ones?
But it's a broad question, but it's one that's worth asking. I think, cancer is a spectrum. Breast cancer is a spectrum. Some lesions are aggressive and need comprehensive treatment. Others are more indolent or slow growing and can be managed with less comprehensive treatments, more targeted treatments. And cryoablation works best at the less aggressive treatment, type of tumors, because they're the ones for which it's an ideal treatment. As you move away from that, it doesn't mean that it can't be a treatment, but it becomes less and less ideal because the complexity of the solution increases. There's a greater need for radiation. There's a greater need for lymph node surgery. There's a greater need for medication. So, applying cryoablation to something that needs those things does not eliminate the need for those things. It only may eliminate the need for surgery, but you need those other things more and more. At the other end of the spectrum, radiation is less important, medication is less important, lymph node surgery is less important. So cryoablation as a substitute for surgery becomes a much easier solution, and the consequences of not doing those other things is much lower. So it's really about figuring out where cryoablation fits in the spectrum and using it in the right way, potentially as a standalone treatment at the indolent end of the spectrum, but as a treatment supported by other things at the other end of the spectrum.
What happened to the Frost trial, and is there going to be another one?
So the Frost trial was a trial sponsored by a company called Sonaris. The company was a company that made the device and also supported the trial. And 2 years ago, the Sonaris was purchased by another company. It was purchased by a company called Hologic. This is all public information, so I can see it. When Hologic was sold, the company that bought it made a decision that it was not going to continue to fund the trial, that they had their idea of doing their own study, and I'm actually helping them develop that study, but that the Frost trial was, they recognized that the Frost trial had limited capacity to change the standard of care because it was a single-arm study that was not randomized. Mm-hmm. To change the standard of care, because it's the rule that we live by currently, is that we need to have a randomized controlled trial. And so they've been in this 2-year process, in the 2-year period, in the process of putting together the pieces to do that study. So that's a meritable goal, and I support it. But it did leave the Frost trial participants sort of in this, catch-22. And so what has become of it? Well, we have continued to provide follow-up with patients that were treated, to seek follow-up with patients that were treated, but we're not enrolling any new patients on the trial. We've also simplified the follow-up of the trial to just yearly screening because the study is no longer funded. So I'm using my staff to do follow-up, but the sponsor of the study is no longer funding it, and Hologic hasn't taken over that. I actually do plan to publish an update of the patients that were treated on the Frost trial. We're actually in the midst of getting a data transfer. They gave me the data from the study went to the new owner, Hologic, which provided me the data about 4 months ago, and I realized that there are about 20 patients that they did not include in that handoff. And part of the meeting that I had with them last week was to get the data that I needed, because I can't publish data on part of it, not include the others, when those others might affect the outcome. So it's required tremendous patience on my part and persistence, because this is not their priority, it's my priority, it's our priority, but we have a responsibility both to the patients and to the world to let people know the outcome of that, good, bad, or ugly, because even when things don't turn out the way not to have a reason that they'll turn out negatively, but we learn from every experience, and we can adapt and improve things based upon that. As the new trial that they conduct will be informed by trials that were conducted previously.
What's the best monitoring after cryoablation, and how often?
I think that it's, I think, this is just opinion, that the best monitoring is a combination of mammography, ultrasound, and MRI. They see different things, and some are best tuned to see some things than others. I think ultrasound, although it's the easiest, is probably the least effective because ultrasound sees distortion. That's how it detects cancer, is looking for tissue distortion. Cryoablation distorts the tissue. So it's hard to tell if there's a new cancer that's emerging within the zone of cryoablation. Now, fortunately, that's not usually where it measures, where it occurs. It usually occurs on the borders. But still, because of the distortion from the cryoablation and the fat necrosis, which may happen, which also distorts the cryoablation image, the ultrasound image, it makes ultrasound a difficult study for early detection of recurrence. Mammography has a role. People don't like mammograms, but if there are new calcifications, then that's a very useful sign. And calcifications usually can be seen long before there's a mass or distortion. So I think there's a role for that. And we also need to, just as a learning curve, understand what cryoablation looks like under the mammogram. That's part of the learning curve that we're trying to establish. MRI also has a role because, and I think it's actually probably the best, because ultimately, for cancer to grow, it needs to have blood supply. It needs to have increased blood flow. And even though there's distortion, you can usually see where the blood flow is increased on an MRI. What we typically expect to see for MRI of cryoablated breast is kind of like an area where the blood flow is increased on the outside, like the shell of an egg, but no increased blood flow on the inside of the egg, which is where the ablation took place. That's the pattern that's most reliable and most consistent with no recurrence. If we see that part of the shell becomes thick or lobulated, then that's an indication that there's possibly something happening at the border. As long as the inside is clear, we're confident about that. But a thickened rind or thickened shell of blood flow around the tumor is one of the early signs that we could detect as a source of recurrence or site of recurrence. So that's why, because they all see different things, I think they all have some value, number one. But MRI is the most sensitive of the three. None of them, however, is perfect.
After cryoablation, how do we monitor it? That's basically what we just said.
Yes.
MRIs with contrast, 6 months, yes.
MRI requires contrast.
This person's saying, I'm following an MRI group and its possible side effects are shocking. Can it be avoided with breast ultrasound or maybe some kind of blood test? You just answered that pretty much.
Well, yeah, we all have free will, and we're all able to make decisions, and they're not necessarily the decision that your doctor recommends, which you all know.
Well, no, we had a good argument about the whole contrast issue for months back.
But you also can't always get what you want. I mean,
No.
To say that if you want to have the most effective screening measure to detect recurrence, then that calls for MRI. If you don't want to do MRI, then you have to accept a lesser effective screening measure and the risk of recurrence. That's an okay decision to make. You just can't have the most sensitive screening measure and not have MRI as part of the mix. So MRI, does come with some risks. Every study comes with some risk, either the risk of the study or the risk for missing the cancer recurrence. And everyone has the ability to make that decision on their own. It's unfortunate, but the reality is that MRI requires contrast. And even though we have entertained some of the non-contrast options, I've seen the studies, and they are completely inadequate for detecting breast cancer recurrence in their current state, as they currently exist, as they currently perform. It's almost not even worth it, in my opinion, to do those studies as a breast cancer detection strategy.
Well, we went through this argument for quite a while back before my 6 months. And in the end, I decided to go ahead and do the contrast. But I did do a lot of detoxing before and after. So I just try to make it as safe as possible.
And that's the way you balance risk. I mean, and I think that there's certainly a lot of people out there that believe in the ability to detox various things. So they use naturopathic methods to fight cancer. I think if they have the confidence that naturopathic methods can fight cancer, I would hope that they have the same confidence that could fight the toxicity of MRI
Well,
contrast.
and you made a good
And-
point with me that if I didn't do the contrast and the cancer was still there, then what the contrast was irrelevant anyways.
Right.
So
Right. So that's the trade-off. So, I think sometimes when you have a hard decision to make, then the decision has to be either to
weigh the risk.
weigh the risk, and that might be to do MRI, with some way to detox, or not do MRI, or do MRI less frequently. But you can manage that risk in different ways.
Right.
But simply not doing MRI ever just might not be the way. If you have a low risk tumor, makes more sense maybe to skip the MRI in that case. But if you have a high risk tumor or a really complicated ablation, then I think it becomes more important. So that's kind of goes on the balance sheet of pro con MRI, whether or not you use it.
What are your thoughts on the ABUS after cryoablation?
I don't think it adds. I don't have any evidence that it adds. So automatic breast ultrasound, ABUS, automatic breast ultrasound.
I actually asked the technician about it the last time I had it done because I ended up in the room with the machine while I was waiting, and she told me that it doesn't work right for cryoablation. That it wasn't the way to go. That was the technician's impression.
Right, and so it's a screening test, and it's a screening test its main value is that it looks at the whole breast. It's a little less user dependent, like when a sonographer does ultrasound, they only capture the image where they point the ultrasound. So if they don't really scrutinize an area or skip over an area, then they might miss something and miss information. So if there's no information, they can't interpret it. The automated whole breast ultrasound looks at the whole breast, and so it captures all of the breast and then uses a computer and other software to kind of render an interpretation. The problem is that when there's distortion from treatment, surgery, cryoablation, its sensitivity to discern whether there's cancer there or not diminishes. It's looking for distortion as a way to see if there's cancer. If there's not been a previous breast disruption, then the breast is kind of pristine. But once you have cryoablation or surgery, you get these other things that are part of the treatment that I think has difficulty interpreting. So I would not rely upon it. I mean, it can be done, but I would not rely upon it as a definitive test to exclude recurrence because of the limitations of ultrasound in general, including automated breast ultrasound.
What is lymph node tracing? What happens with lymph node tracing? And is it possible to have cryoablation after lymph node tracing? And how do you know there's nothing that made it to the nodes if they're not checked?
So it's I'm going to try to answer that in parts because
what's lymph node
so
tracing?
lymph node tracing. So I think by the term they're used in lymph node mapping, which is a technique, the term that we use for identifying the lymphatic drainage pattern of the breast. Typically, there's a predictable pattern of drainage of lymphatic fluid, watery fluid, from the breast to the lymph nodes. It tends to be in a fairly orderly way. It goes first to one or two nodes, then to the next level nodes, and then to the next level nodes. And so when we do surgery and we do a central node biopsy, we usually inject the tracer into the breast, either a blue dye or radioactive tracer, which travels from the injection site to the first lymph node and then to the second lymph node. And so if cancer were to follow the same pattern, which is the principle, then it would first go to the first lymph node and then to the second lymph node. So if we can trace and identify the first lymph node and check that lymph node, and there's no cancer there, it gives us relative confidence that there's no cancer in the remaining downstream nodes. On the other hand, if we find cancer in that first lymph node, it raises concern that there might be some cancer in the remaining downstream nodes. That's how lymph node tracing works and why we use it. Now with cryoablation, since there's often no lymph node procedure, there's no role for tracing, because even if you can inject the substance and show it goes to that node, unless you can evaluate that node microscopically, you can't say for certain there's not disease present. We use ultrasound typically just to see if there's gross evidence of lymph node involvement. The node looks a little thickened or misshapen, that would be a sign. But a normal looking node doesn't mean that there's no cancer cells in them. It just means that the burden of disease in the node might be so low that it hasn't distorted the cells. So, that's why even with cryoablation, you have to think about the lymph nodes. You first start with, well, is it a high-risk tumor versus low-risk tumor? For the high-risk tumors, I still recommend a lymph node procedure, surgical procedure. For low-risk tumors, there's more latitude to not do so. You also have to think of, well, if there is microscopic disease, how can I control it without surgery? One rule is with radiation. So when you radiate the breast, it often treats a portion of the nodes, and radiation works great for microscopic node disease. So that's a way to control nodes, even if you don't remove them. But ultimately, the only way to know for sure whether there's disease in the node is to remove it, or to follow it over time to see if there's recurrence.
What do you think about immunotherapy following cryoablation? There's an article enhancing cryoablation with immunotherapy.
So this is an exciting area of research that is still fairly immature. We know that cryoablation has the ability to induce an immune response. It's been pretty well shown in animals that works. We also know, primarily from animal studies, that in some cases, that immune response can have a systemic benefit to reducing cancer growth. We don't have human studies that clearly show that. And we don't have studies that clearly show that an immune response equals a systemic benefit. Just because you get a response doesn't mean that response is protective. So one way that immunotherapy is being looked at is as a way of sort of amplifying the immune response. Because maybe you get a response, but it's not strong enough, so you need to spike it with the drug. And that's what immunotherapy is about, trying to increase the immune response. And that's a research question currently. The most mature study that's ongoing is looking at the use of cryoablation for triple-negative breast cancers treated with immunotherapy. And so actually, people come to me with triple-negative breast cancer, I refer them to that trial because I think that's the most provocative and informative trial. That trial requires that they have chemotherapy. So that's one of the barriers. But basically, the design of the trial is that the patients that have chemotherapy for triple-negative breast cancer, if they have remaining disease left, if the disease hasn't disappeared after the chemo, then they are qualified for cryoablation of the tumor combined with immunotherapy, and then they go on to surgery. But the idea is to really kind of ramp up the immune response to this tumor that otherwise looks resistant to chemotherapy, to prove that adding immunotherapy will improve the outcome. And the preliminary results look great for those patients. So it's a reason to continue. But I would just conclude by saying that there are a number of people in the world that are doing cryoablation and then adding an immunotherapy drug without any proof that it actually benefits. So you can do it, but the question is, do you have any data in humans to show that this actually works? And for some people, they don't need proof that it works. They're willing to try, that's fine. But they have to be upfront about that. And it's really, since this is such an important question, I challenge people doing that to do it in the context of a trial, because we really do need to learn, understand how it works, where it works, if we need to change it in some way to make it work better, and simply to do it because you can or because you can charge for it really does a disservice to cryoablation as a treatment option, and definitely immunotherapy as a treatment option.
What's your latest opinion relevant to cryoablation on an armpit sentinel node versus radiation or chemo for a patient who already had cryoablation of breast tumor, HR positive, PR positive, HER2 negative, and postmenopause taking only letrozole for maintenance?
Are you sure there's not a non-cryo question?
Yes.
Okay, let's
go here.
Let me answer that because they raised one new question, and then we'll move on to some non-cryo ones. So
definitely.
the question, the new thing that emerged there was cryoablation of a lymph node, I think.
Yes.
And so I think surgery is better for lymph nodes when the patient is willing to have it performed. But for those unwilling to have surgery of the lymph nodes, I think cryoablation of a positive node is an option. The reason why there's a difference between surgery of a positive node or cryoablation of a positive node is that when we're starting I'll preface it by saying that the goal is to minimize the extent of lymph node treatment, just to kind of deal with the disease that is clearly established and not take away healthy nodes. So one of the things that we get when I take a patient to surgery to do a lymph node, to remove a suspicious node, is that I get to feel around in the underarm area amongst the lymph nodes. And we can often find abnormal nodes that are not big enough to be seen, but that feel clearly abnormal based upon experience and so forth. And when I do that procedure, I will take those nodes out and include them in the specimen. And so I think you get that additional tactile benefit that you don't get with ultrasound when you take a surgery. With cryoablation, we can only aim for what looks abnormal, and those other nodes just will be maybe missed if they're not part of the field. And so there's a higher risk that there'll be untreated nodes. Now, ultimately, with either approach, whether it's with cryoablation or with surgery, I think the one essential element that people need to consider is radiation. Because when they have one grossly abnormal node, likely there are others, even if they look normal. And those they look normal, but they may have microscopic disease in it. Radiation works great for that problem. And many of these patients that have one node that don't want to do anything more are likely to have recurrence in other nodes in the next 2 or 3 years. So radiation kind of solves that problem, I think, very well, without the burden of adding the risk of lymphedema. Because radiation, when you do radiation with limited surgery, the risk of lymphedema is quite low.
What possible links are there between genetics and Paget's? Is nipple suction, such as nursing or enthusiastic partners, connected to Paget's? This person was nursing when their Paget started, and the infected breast was the one that they preferred to nurse on. Is it possible that the cancer cells got sucked into the surface area by?
So I think that's probably just a series of rare events, meaning that I have not seen any evidence to show that there is association between breastfeeding or nipple stimulation and Paget's. And there are also no studies that clearly show that there's some unique genetic risk to developing Paget's disease, either genetic mutation or genetic injury. Paget's cells have a unique genetic signature, but it's just because of kind of how what they arise from. But it's not something that's hereditary, or it's not something that is increased or decreased because of a lifestyle or community exposure. So I think I might have answered all of those questions. Did I?
I think so.
Okay.
Is there?
If not, hopefully it'll.
We got more Paget's here.
Okay.
Is there a relationship between Paget's, dense breast, and HER2?
So what is Paget's disease? Let's start there.
Yeah, that's a good one.
So
I know that one. I had it.
So Paget's disease is primarily the outcome of cancer growth through the milk duct that invades the skin of the nipple. In most cases, that's the source, that there's an underlying breast cancer that works its way through the ducts, through the lining of the duct, and then penetrates the skin of the surface of the nipple. Initially, the skin looks normal on the surface. Maybe there's a little itching, but it has a normal appearance. And eventually, over time, the normal skin surface, like you have surface of your skin, the pigmented skin, gets displaced by the tumor, which emerges from underneath. The tumor just displaces the skin, and then you're looking at the surface of the tumor at the nipple. That's the most common scenario. There is a type of a presentation of Paget's where it actually arises in the skin of the nipple, not from an underlying breast cancer, but there are these unique cells that are present in the skin of the nipple that they themselves may develop into Paget's disease. But in either case, it's a disease that manifests at the nipple surface.
Looks like eczema.
In fact, one of the first symptoms and things that's often confusing about it, and often way it's misdiagnosed, is that it looks like a rash. Might itch, but it looks like a flaky rash involving the surface of the nipple. An important distinction between eczema and Paget's is that primarily Paget's arises from the nipple, and eczema often arises from the areola. Of course, Paget's can extend from the nipple to the areola, but the general pattern is areola. That eczema is an areola problem, not a nipple problem, and Paget's is a nipple problem primarily that can become an areola problem.
I went through a lot of doctors that told me I had staph and I had eczema and I had everything else but Paget's. And even the ones that I told them I thought I had Paget's wouldn't believe me. So
I guess they just need to expand their experience, but hopefully they've learned from your experience. And so next time they see that, Paget's will enter their heads.
Hopefully.
Yes.
ER negative. Well, is it related to HER2 at all?
So the evidence indicates that there is a higher potential for Paget's to be HER2 positive. That's in the studies that looked at Paget's that we've written about in the paper that is under review currently. It was observed and reported that there's a higher manifestation, but that is also true because of the following. This might be more detailed than you want, but in the development of DCIS, Paget's is a form of DCIS.
Oh.
In the development of DCIS, there's a higher potential for DCIS to be HER2 positive than invasive cancer. In fact, if you look at all the DCIS in the world, we don't routinely test for HER2 in DCIS because we don't treat it. It's not a target for treatment for DCIS. It's a target for treatment for invasive cancer. But if you were to routinely test DCIS for HER2, the numbers that I've seen is that about 60% of them are HER2 positive. And that's what we see with Paget because it is a form of DCIS. But that doesn't mean that your HER2 positive DCIS will become HER2 positive invasive cancer. It often switches when it invades. And so that's kind of what we've seen.
Okay. ER/PR negative, HER2 positive cyst was 4 centimeters. Another cancer in the area by the breast wall and 2 different areas of lymph nodes. What would be the factors of recommending mastectomy versus lumpectomy?
Well, often the decision about lumpectomy versus mastectomy is simply an issue of tumor size and breast size. That's really the driving factor 9 out of 10 times. So if it's a unifocal tumor and you can remove it with an adequate margin and preserve adequate breast volume, then most tumors are a candidate for lumpectomy. We also have the ability for some tumors to pre-treat them with drugs. So if it's maybe too big to allow lumpectomy, but you can shrink it down to smaller size, then it can convert some tumors that require mastectomy to ones that can be treated with lumpectomy. We call that neoadjuvant chemotherapy or neoadjuvant endocrine therapy.
Is that true for cryoablation too?
Yes and no. So you can, at least in theory, shrink a tumor down, but the problem is that when tumors shrink, they don't always shrink in a reliable way. Like some tumors, they may shrink like that. Others may shrink like, when the water recedes from the ocean, it leaves little puddles on the beach, and when the tide goes out. And so for a patient, if you're going to do surgery and you're going to, kind of cut through the area from which the tumor receded, and at least get to look at whether or not there are any cells remaining in the wake of the receding tumor. With cryoablation, you don't get to determine if there are any cells left in the wake of the receding tumor. So my own belief is either you simply treat with cryoablation up front, or if you treat with cryoablation after pretreatment, then you treat the original volume. The difference between cryoablation and surgery is that with cryoablation, you can treat a bigger volume without affecting the breast appearance because we're not taking the tissue away. With lumpectomy, if you took away the original volume, then you'd have a significant cosmetic defect. So we do have the latitude with cryoablation to treat a larger volume because we're not altering the shape of the breast by taking away a large volume of tissue.
If the cancer was removed and not detected in lymph nodes, would Dutch be the best? I assume they're talking about the Dutch test.
Is.
Oh, okay. Well, there's a test called the Dutch test.
I don't know. What do you know about the Dutch test? I don't know.
Not a whole lot. I mean, I hear about it all the time.
We'll have to do my homework on that and come back to that one maybe in the future.
One of your patients is researching it, and I should tell her to let you know about it.
Okay, please do.
What is postpartum breast cancer?
So postpartum breast cancer is breast cancer that's diagnosed within a year of pregnancy, within a year of childbirth. And actually, I have several patients now that presented with postpartum breast cancer. We also have the term pregnancy-associated breast cancer, which is within a year of pregnancy. So it's in either direction. It's pregnancy-associated breast cancer, but it can be its own challenges. Can cause. Postpartum is an easier problem to treat because at least the baby's out, and so you don't have to worry about the treatments and the effect on the baby. It just can be more challenging to diagnose because the breast after pregnancy is different in shape. There are new lumps, breast volume has changed, the breast density has changed. It's harder to evaluate with the mammogram because the density is high. MRI is not so great because the blood flow is already quite increased. So it's harder to see something growing early. And so that's why postpartum breast cancer can be a challenge to diagnose. But the treatment is the same as it is for one that is not, for just breast cancer in a woman that was not pregnant. The more challenging one is pregnancy-associated breast cancer for when there's a baby intact, because you have to be careful about when you do chemotherapy. You have to be careful about when and if you get radiation. You have to be careful about when you do surgery. And it all has to be timed in sequence so that the baby isn't lost in the effort to treat the mom.
Okay, back to Paget's. Is it likely to recur? We already talked about the HER2 and the ER/PR. Is it likely to occur, and when a recurrence happens, is it in the vessels of the skin? This person always thought theirs looked like their body was trying to regrow a nipple.
So if Paget's is like DCIS, which means it doesn't get into the bloodstream. It doesn't, and so it grows, sequentially, from one spot to the next, just so it penetrates. But it would be between the cells. It would not be within the milk. Within the blood vessels. It would not be within the blood vessels of the skin. Now, if it becomes invasive at any point, then it can get into the blood vessels and spread through the blood vessels. But it expands in kind of an inward to outward direction, just in a very direct way. It doesn't metastasize or it doesn't get into the bloodstream to travel in that way, unless there actually is an invasive component present that then can break away and go into places.
So basically, once you've got clear margins, it's gone, stays gone.
Right. Now, at the skin level, once you have clear margins, it's likely gone. In the breast, you can still have multifocality, other spots. So you need to have clear margins. But if you get clear margins, you have reasonably high confidence that it's gone. Of course, we still recommend radiation and medication because even when we have clear margins, doesn't mean it's completely clear. There could still be something more. But a skin margin that's clear is probably all that's needed with Paget's, because it doesn't have a skip pattern of growth. It has a continuous pattern of growth.
You had a double mastectomy. Would the Paget's have been treated even if it wasn't diagnosed?
The double mastectomy with removal of the nipple and areola, it would have been treated. If it was a nipple-sparing procedure, it would not have been treated.
Is there any sign we can look for that the cancer is reoccurring?
Well, the best sign is to have no indication of recurrence. But if you have a recurrence, the best way for it to be detected is on the screening study, like on a follow-up mammogram or follow-up ultrasound or follow-up MRI, because that's the study where it's likely to be found at a size that's not yet large enough to detect by exam, by feeling it, or by feeling a lump, or by having symptoms. So, usually for patients with breast cancer, screening yearly is sufficient. You don't need to screen more often than that. But what we're looking for are early signs of recurrence.
I think they're asking if there's any signs that you can see.
Right, but my point is that I'm hoping that you don't get signs.
Well, yeah,
right.
Obviously.
But if you are not screening, or if the screen fails to detect it, then what you would likely see just is the same as the thing you'd see in a normal situation: a lump. A lump, most commonly at the lumpectomy site, because cancers have the highest tendency to recur in the original place where they were found, at the borders of the original place that they were found. You can have thickened scar, like a nodule in the scar. The lumpectomy scar would be an area of indication. You can have it recur as a pimple in the skin, because lobules especially tend to like to recur in the skin as like a little pink raised pimple. You could have a lymph node that was previously normal that looks abnormal. That would be an indication of recurrence. And you can have, very importantly, new calcifications that appear, especially if the previous cancer had. But that's not a symptom. I mean, it's a radiographic sign, but it's not something that you would detect by exam.
If you have DCIS that started as a papilloma and more developed, and does the fact that one papilloma becomes DCIS raise the risk that others will as well?
I think if it's in the same region of the breast, there's a tendency. There are some manifestations of DCIS that's a papillary DCIS, meaning that it's a DCIS that presents with papillomas and has a tendency to form papillomas. And so if you have papillary DCIS, which is basically what you described, in one part of the breast, and you have another papilloma in another part of the breast, my concern would be that it's part of the papillary DCIS process and that it displays a similar behavior. If it's in the other breast, I think it may just be a regular papilloma. But if it's in the same breast, I think if you're one papillary DCIS, you're likely to have others. Or you have a higher chance of having other papillary DCIS lesions in that breast.
Can a 40-something-year-old saline implant still be a non-risk in the body?
We don't have any independent indication that, like, studies that show that it's a harm. Now, what is a risk? Is there a cancer risk? There clearly, I don't think there's any evidence at all that any implant increases the risk of breast cancer. So that, I think you put that one aside. There are, recently some concerns about, textured implants, but textured implants weren't made 40 years ago, so that wouldn't be the problem for that patient. The other things are, there's chronic changes around the implant. Might make it sometimes hard to detect the cancer, but not a cancer risk. Sometimes the implant wall gets calcified, gets hard. So I think there's no specific cancer risk that I can associate with a very old implant like that. But it's, if it's ruptured, which it very well may be, there's certainly no benefit to leaving the foreign body in place.
I've met some people that there's ruptured in with immune issues because of it. What about genetic testing? Where's the field going in the near future?
Well, it's quite dynamic. I was at a meeting, kind of a key opinion leaders meeting 2 weeks ago, and there were several of the genetic testing companies there where they kind of present their, technology and talk about what they're doing now and where they might want to go, and just asking our feedback about it. And there were several themes that emerged. The most important theme that emerged is that genetic testing is underutilized. That there are probably 80% of the people that have an actionable genetic mutation don't know about it because they're not tested. And that could be, and the people that we learn about, for the most part, are people that we learn about because they come in and they're diagnosed with breast cancer or a mutation-associated cancer, and we test them, and we learn it's present in their family. But that doesn't mean that their family members get tested or that people that don't yet have a cancer diagnosis, get tested. The ideal is to diagnose you before you have a cancer so that we can offer you something preventive or risk reductive. But that's where much of the focus is on now. It's not an elegant answer, but that's the reality. The reality is they're trying to figure out how can we get, for commercial reasons as well as for ethical reasons, how can we get more tests done for people before they get diagnosed. And so one of their strategies is to figure out how they can get it in the hands of the primary care docs so that the primary care docs will be more routinely testing so that people can be diagnosed before they actually develop a cancer diagnosis.
Is HER2 have a genetic component?
No, it's not one of the hereditary types of cancers.
So my kids don't have to worry about
it. And I'm just checking the clock. We have 5 more minutes. So I know we have many more questions. So why don't I just leave that one with that? Because that's the most important thing about where they're going.
Okay. Can you please discuss invasive tubulobular carcinoma? And how often is it diagnosed, statistics of reoccurrence, and why it's challenging to treat?
So I'll make this one quick because I've partially already answered the question. Tubulolobular is a form of lobular. And we talked about how lobular can be challenging because of how it manifests itself. Lobular cancers are about 5, at most 10% of breast cancers, and that's about 1% of breast cancers.
Okay. Someone has grade 3, how likely is it to return? And if it does return as invasive, does it return just as aggressive as the previous grade 3, or will it be more aggressive?
So by the framing of the question, it sounds like they have grade 3 DCIS, and they're asking how likely is it to return as invasive cancer? How likely is it to progress to invasive cancer as a recurrence? I would just say that the higher the grade 3 is the highest grade, the more likely it is to either recur as DCIS or recur as invasive cancer. When someone has DCIS and it's inadequately treated and it recurs, about half of those recurrences is an invasive cancer recurrence. And the ones that are more likely to recur are the grade 3 versus grade 1. It's
Well, if it's already grade 3, it can't be more aggressive, can it?
It can't be a higher grade, but it can be invasive.
Okay.
So that's the range difference. If a grade 3 in DCIS is inadequately treated, it may come back as a grade 3 invasive cancer, which really escalates the obscenity.
What is the abscopal effect?
That's a cryoablation question primarily, but it's also a radiation question. Basically, it refers to the idea of if you treat the site, that there will be an immune response to that site that will have systemic benefits. It's something that we're currently exploring, trying to harness for cryoablation, but it also is a feature of radiation as well.
By the time tamifloxacin does its job, would you qualify for, I guess they're asking cryoablation? What is your thoughts on a 5 milligram TAM study?
That's basically a question about low-dose tamoxifen. There is some evidence that low-dose tamoxifen can work well for DCIS, that patients might not need to have the normal 20-gram dose. And there might be a study looking at invasive cancer. I don't know the data about that, but I think there will be some room to move towards using lower doses of anti-estrogen therapy for the right patients, because you might get the same benefit with fewer side effects.
Okay. What's lymph node sparing surgery, and is it a common practice?
So that's a fairly generic term that I use to apply to a number of things. But lymph node sparing surgery starts with not doing lymph node surgery in situations that don't need it. And most people with stage 1 breast cancer, women over the age of 70, estrogen receptor positive cancers, don't need to have any lymph node surgery at all. So that's lymph node sparing surgery. There's also the technique of sentinel biopsy. That's a lymph node sparing procedure. We take out the lymph node that is important, leaving the others in place. But there's also for people that have positive nodes, where you make a decision, okay, I'm not going to remove all the nodes just because your node is positive. I'm going to remove the grossly abnormal ones and treat the remaining with radiation. That's lymph node sparing surgery. And then lastly, there's axillary reverse mapping. It's not the lastly, but I'm just going to say the next one is axillary reverse mapping, a technique whereby we inject dye in the arm to visualize the arm drainage so that we can identify the lymph nodes that drain the arm and spare them during surgery to avoid them, because it's removal of those nodes that increase the risk of lymphedema.
Okay. Can you?
And the final question.
All right. Can
Make it a good one.
How about targeted interoperative radiotherapy and what the qualifications are?
Okay, so that's an area that I've been experimenting. I mean, I sort of cut my teeth in this, not cryoablation, if you will, since this is what I'm most known by. Well, up until recently, what I've been most known by. Radiation given during surgery. I was part of the pioneering research in the U.S. to establish this as a treatment option. It is now established as a treatment option that's fully reimbursed and covered by health plans. But it's a way of giving radiation as a single treatment during surgery, as opposed to the usual 4 to 6 weeks of radiation that is currently given after lumpectomy. So it's for lumpectomy patients with tumors that are generally 3 centimeters or smaller, ideally lymph node negative. When they go to surgery for their lumpectomy, we can give their single dose of radiation at the time of the lumpectomy with no need for further radiation, as opposed to the usual scenario where someone has lumpectomy and then after a few weeks of recovery, begin a 4-week course of daily radiotherapy.
Can you do it if you have more than one tumor?
We can do it. Case-by-case basis, they need to be clearly separate tumors where we can treat one area and another area.
I just asked because it was recommended to me when I first got diagnosed.
Right, but these have to be small tumors, and each individually very good candidates for lumpectomy. That's intraoperative radiotherapy, and unfortunately, our time has ended. It was fun.
Yeah.
We should
It's
do it
always
again.
fun.
We should do it again.
Oh, I'm game. I love doing it. I learn a lot from it, from the questions.
Well, I also learned a lot. I learned from the questions because I understand what people are thinking about, and also, how to answer the question, because some of these might be very simple, but they're not really. It may be simple to me, but they're not necessarily simple to explain. And so I learned from the process of explaining as well.
And these are not my questions. These are questions I collected from all the different Facebook groups I'm in.
So thank you, Facebook, for this at least, and thank you for your time and your advocacy, your mission work, ministry. It's a privilege to have you join me for this and to try to make this more interactive and less more like a lecture. Sorry I speak so fast, but there were many questions that didn't quite get to, so maybe
Well, a couple of them with some I just threw in case we had extra time.
Thank you. But this is the end of this year's webinars. We'll do more for next year. We just haven't released the schedule yet, so stay tuned for that. And thank you for spending part of your weekend with us, and wish you all the best. Thank you again for joining me.
You're welcome. Anytime.